All right, so in this first session, we're going to continue to hear about Project Room Key. Sandra Mukasa is the Policy Research Coordinator at Los Angeles Homeless Services Authority. And then we'll also be hearing about the impacts of hotels as non-congregate emergency shelter during COVID-19 in the state of Washington. And we'll be hearing from Dr. Rachel Fayel, who is the Associate Professor at the University of Washington, and Dr. Christina McHugh, the Regional Housing and Homelessness Evaluation Manager at King County, Washington. So Oregon, let's welcome our friends from the rest of the West Coast. Thank you. Sandra, we'll have you up first.
Great, thank you. As my slides are coming up, hello, good morning to those on the West Coast and good afternoon to others in other time zones. My name is Sandra Mukasa and I use she, her pronouns. And I'm the Policy Research Coordinator at LAHSA, which is the Los Angeles Homeless Services Authority. And LAHSA is the Joint Powers Authority of the City and County of LA. And we're tasked with leading the coordinated homelessness response for the county. And LAHSA is also the lead agency for LA's continuum of care. Next slide, please. For this presentation, I'll provide an introduction to homelessness in LA before I address LAHSA's COVID response. I'll dive into our largest pandemic response program, Project Room Key, and ways we've tried to strengthen racial equity within the program. And I'll close by providing a preview into how we're using equity tools within the newly allocated emergency housing vouchers from the American Rescue Plan. Waiting for the slides to advance, please. While that gets started, I'll keep going. So with about 568,000, one more slide, please. With about 568,000 people experiencing homelessness nationwide, over a quarter of those people are located in California. Next slide, please. There are over 66,000 people experiencing homelessness across LA County on any given day. Every day, approximately 207 people are rehoused through our system, yet 227 more people are pushed into homelessness. Next slide, please. Black people make up 8% of the population of LA County, but are more than 1/3 of its population experiencing homelessness, an overrepresentation that is unfortunately consistently seen in other US communities. In 2008, LAHSA released a report by our ad hoc committee on Black people experiencing homelessness. The report shows how structural racism, discrimination, and unconscious bias in housing, employment, criminal justice, and child welfare policies have led to this overrepresentation of Black people experiencing homelessness. After the culmination of 9 months of work, the report outlines 67 recommendations to create a broad framework that will advance equity and eliminate these racial disparities in our county. This report has helped our homelessness response system develop a shared language for articulating how structural racism has led to racial inequities and ways we can collectively work to eliminate them. Next slide, please. Our homelessness response and rehousing system pivoted to a rapid life-saving mission at the outset of the pandemic. While the work I'm focusing on today is driven and shaped by LAHSA, the larger COVID response work of supporting people experiencing homelessness in LA would not have been possible without the tremendous effort and collaboration with other public entities and service provider agencies. At the beginning of the pandemic, it was estimated that at least 15,000 people experiencing homelessness in LA County were at high risk of severe illness, hospitalization, or death from COVID. Therefore, housing them in safe, non-congregate settings became our first priority, and Project Room Key is the name of our non-congregate shelter program. As the pandemic has continued on, our focus has shifted to permanently housing those who have been sheltered through Project Room Key and thousands more of the COVID vulnerable, using a recovery roadmap developed with our city and county partners. Project Home Key, the acquisition of hotel properties for permanent housing, is one component of the LA's recovery rehousing program. Next slide, please. In launching Project Room Key, or PRK, in March of last year in partnership with the state, city, and county, LAHSA set a goal of housing the 15,000 COVID vulnerable in hotels and motels. Using information from the Centers for Disease Control, we developed a new assessment to determine COVID vulnerability and thus eligibility for PRK enrollment. Within weeks of its launch, thousands of people were enrolled, sheltered, provided with daily meals, and connected with supportive services. Next slide, please. From the beginning of PRK, there was concern about how to ensure equitable access across race and ethnicity groups and remove any implicit or explicit bias. We recognize that inequity could impact PRK in two main ways. One, through who was referred, two, where the sites, PRK sites were located, as participants typically came from the immediate site surroundings. One step taken to correct this was telling homeless services providers in early May 2020 to comprehensively review their caseloads and speak to all clients to determine whether they are eligible for PRK. This was our way of trying to get both a better picture of who may be most vulnerable during the pandemic, and also to ensure that all eligible and interested persons were referred. While this push for comprehensive case review was important, we recognize that additional steps needed to be taken to ensure that PRK enrollments were as equitable as possible. On this slide are charts detailing LA County's COVID-19 data from last year. In the spring of, our urgency of ensuring racially equitable access was fueled by data that began to emerge in the spring of last year, that within California, there were disproportionately high numbers of COVID cases and deaths in Black, Latinx, Indigenous, Native Hawaiian, and other Pacific Islander communities. Next slide, please. This slide shows a snapshot of PRK demographic data on June 11, 2020, as compared to the 2020 Greater LA homelessness count estimates. So this was prior to any adjustment of PRK enrollment strategies. While people from all racial and ethnic backgrounds are enrolled in PRK, the majority of participants are Black, Latinx, or white. This June 2020 data showed us that in comparison to the homeless count, both Black and Latinx participants were underrepresented in PRK, while white participants were overrepresented. Thus, considering both concerns about racial and ethnic disparities in PRK enrollment and the disproportionate impact of COVID-19 on communities of color, there's a clear need to craft an appropriate approach to address these disparities. We believe that developing a new strategy for racial equity within PRK enrollment could be a test strategy for improving racial equity within our system. Next slide, please. In order to support the process of identifying those at highest vulnerability to COVID-19, we were mindful that using solely race and ethnicity as a factor for PRK placement would be both inadequate and impermissible under Fair Housing Act. However, using neighborhood level data can be a suitable proxy for identifying levels of vulnerability in a region. Research has shown that high poverty neighborhoods and neighborhoods of color are disproportionately located near sources of diesel and air pollution, which may trigger asthma attacks and other respiratory problems. Developed by a California State Environmental Agency, CalEnviroScreen is a science-based tool used to identify level of cumulative environmental hazards and burdens for California neighborhoods. Neighborhoods are mapped at the census tract level and scored and scaled based on environmental, health, and socioeconomic information, giving cumulative scores that run from 1 to 100 and indicate low to high level of impact. Next slide, please. There's precedent for using CalEnviroScreen in order to advance environmental justice and racial equity in programs across California. In defining the appropriate geographic-based proxies for vulnerability, we focused on areas in the 95th to 100 CalEnviroScreen percentile range in order to identify the most disadvantaged communities when it comes to environmental injustice. Areas in the 95 to 100% CalEnviroScreen percentile range, this highest range, face the highest level of pollution burden. Within the context of LA's coordinated entry system, we work within the geographies of service planning areas, or SPAs, and their subregions. Therefore, we designated SPA subregions that had high concentrations of residents who live in these highest CalEnviroScreen ranges as most disadvantaged communities, or MDCs. These MDCs have existing neighborhood factors that exacerbate their population's vulnerability to COVID. Next slide, please. Los Angeles has 8 service planning areas, or SPAs, and each SPA has subregions within them. 14 out of 34 SPA subregions were categorized as having a most disadvantaged community designation. All other subregions are referred to as non-MDCs. Next slide, please. Starting in June 2020, the centralized PRK matching team at LASA began to use a new enrollment strategy involving specific percentage allocations for referred individuals from MDC and non-MDCs. Each subregion list was assigned to a particular PRK site or sites. This slide shows a flow chart of how PRK matchers went through the process when working a particular subregion list of referred individuals. Starting at the subregion level, the matchers first filtered to those with 2 or more COVID-19 risk factors and made matches going from those with longest to shortest length of time of homelessness documented. Once the referral list of those with 2 or more qualifying health conditions was exhausted, matchers then moved on to matching individuals with 1 qualifying condition. Next slide, please. Altogether, this new strategy was created in order to first ensure enrollment of individuals coming from most disadvantaged communities, since these neighborhoods have faced the highest levels of environmental injustices, which in turn exacerbates COVID-19 vulnerability. 2, correct for limited access to PRK sites for individuals from MDCs. And 3, protect against implicit bias by having matchers enrolled individuals based on length of time individuals that has experienced homelessness and number of qualifying conditions. When it came to implementation, individuals from the MDCs closest to a PRK site were prioritized for matching to a site's MDC slots. Next slide, please. To give a picture of the shifts that occurred during the summer of 2020, using this new MDC-focused enrollment strategy, I'm showing a chart which displays the extent by which the Black, Latinx, and white groups are over or underrepresented in PRK as compared to the homeless count estimates of 2020. These 3 groups represent the vast majority of PRK enrollees. Negative numbers below, with bars below the middle 0 line, indicate underrepresentation of that group, while positive numbers with bars above the 0 line indicate overrepresentation. This chart shows 3 time points for each group. First, right before the implementation of the strategy, then 4 weeks into the strategy, and then 10 weeks into the strategy. The chart shows that there was some movement for all 3 groups. Black and Latinx participants became less underrepresented 10 weeks into the strategy, while white participants were slightly less overrepresented. This strategy was large.
Sandra, I just wanted to do a little ping on time. We want to make sure we have time for Q&A.
For sure, yes.
Awesome, thank you.
So this strategy was largely in place only from mid-June to August, and the strategy was only able to be implemented with full fidelity, was not able to be implemented with full fidelity after August because of the closure of PRK sites started to occur. So there was a reduction in the slots available for new PRK participants as some existing PRK participants were shifted between sites. Next slide, please. So the central goal of PRK Ramtown was that no one was to exit from PRK to the streets, and the initial goal was for PRK to fully close down at the end of last year. However, with the COVID surge, many sites have continued open up until today. Next slide, please. For my final minute, I'd like to share how we started to think about how to apply equity-based tool to matching of emergency housing vouchers. Thanks to the federal passage of the American Rescue Plan, 6,800 of these vouchers are being made available for allocation through our coordinated entry system. Next slide, please. In June, we passed an interim policy for matching and prioritization of EHVs. Within the policy, we outlined potential equity tools to use in the implementation of these housing resources. And so coming off of our pilot experience of using coronavirus screen, analysis within PRK, MDC statuses include as a framework to use in order to inform outreach strategies and in order to review, in ordering the review of applications. Next slide, please. That's fine, you can skip to next slide, please. So with that, I'll close. It's been an honor to be able to share some of our recent work in LA related to racial equity and our COVID-19 response. And I look forward to questions and conversations throughout the rest of the symposium and beyond. Thank you.
Thank you so much. Just a reminder to folks, we are taking questions in through the chat. Be sure to send them to everyone, not just the presenter, and we'll be asking them shortly. Next, we want to move on to Dr. Rachel Fial and Dr. Christina McHugh from the Regional Housing and Homeless Evaluation Manager at King County in Washington.
Sorry about that. Hi, good morning and welcome. I'm going to start sharing my slides here. We are delighted to be with you this morning and talk about some research that is, I think, very complementary to the other presentations we've seen so far this morning, thinking about the impact of hotels as non-congregate emergency shelters. So I'm going to offer just a little bit of background on the study and then hand it over to Christina for a bit. We'll do a bit of back and forth. A little bit of background on our work. Immediately following the outbreak in March 2020, King County, which is the county that houses Seattle, moved over 700 people out of shelters into hotels. The primary purpose of this intervention was public health and safety. And as we've already heard, all of the good reasons to get folks out of those dense congregate shelters and into to better spaced, socially distanced places, both for the health of those in shelters as well as larger community effort. This was a remarkable effort and collaboration between government and service providers. And we really had the privilege to participate in, I think, coming together in the fastest research I've ever been a part of, a collaboration between UW and King County and some of our local funders putting this into practice. This is a mixed methods study. We used quantitative data provided by administrative data sets, so HMIS, Washington Disease Reporting System, and 911 Emergency Dispatch, as well as qualitative data from 22 interviews with hotel shelter guests and some interviews with 9 staff members from the nonprofit providers, city and county, all used who all participated in the implementation of this process. And really the goal of the study was both to find out like what's going on and how did it go, and also to inform future responses to homelessness. Now, at the time we were doing this research, we had no idea that we would still be talking about pandemic responses. So I just want to flag that this research project, we stopped collecting data about a year ago in September 2020. And we can tell you kind of less formally about the impact of our study and how it's helped shape some of King County's future responses during the pandemic. But at the time we were doing it, we really thought, okay, we got to get these impacts in now before life goes back to normal and whatnot. So just keeping that in mind, that our research is really focused on what happened in that first summer of COVID. And yet we continue to see the relevance of this research. So now I'm going to turn it over to Christina to give some more background.
Thanks, Rachel, and thanks for having us here today. So as Rachel mentioned, I'm going to take over for a little bit and give some background on King County shelter system and our study groups. So King County has and had a large network of programs and providers that offer a range of emergency shelter services, from the most basic, just a hot meal and a safe place to sleep, to more enhanced services that might offer things like case management, medical care, and mental health counseling. And you can see kind of 2 photos of what these environments looked like in our community prior to the intervention that's the subject of this study here. And so these are 2 shelters that actually shifted over from congregate to hoteling at that time. So according to our 2020 housing inventory count, we had more than 5,000 beds that were part of 112 programs for adults, families, and youth. 60% of that inventory is managed by the 5 largest shelter providers, and more than 25,000 households went through a King County emergency shelter at some point in the kind of rolling year prior to the beginning of our study period. And those beds are more often than not full. We regularly run a fairly high utilization rate. Next slide, please. Thank you. But like everywhere around the country, our shelter system had to adapt quickly due to COVID-19. High density congregate shelters were particularly vulnerable to large outbreaks of infectious diseases like COVID-19. And so in order to allow for social distancing and to slow the spread of the virus, King County and its partners used 3 strategies, and 2 of those are focuses of the study. First, group hoteling. So we leased 6 hotels in their entirety and shifted all provider staff over to those sites. They were open 24/7, had case management and access to other services. We also had some de-intensified congregate shelter sites. These were essentially large shared rooms, just as our shelters traditionally have been. But in this case, the beds were spread out and capacity was reduced in order to meet social distancing requirements. And then the last intervention that we don't focus on here, but just to acknowledge that we did this, was that we also issued some hoteling vouchers. So these were not hotels that were entirely used as shelter. They might have had regular guests in them, and they were sort of more scattered, and there were less services offered directly on site. And so for the purposes of the quantitative component of the study, we split a cohort into 3 groups. Group hotels that offered private rooms and bathrooms, that open 24/7, had case management, and then enhanced congregate shelters. So these were de-intensified but did not have private rooms and bathrooms. And then last, a congregate shelter with basic services. So these, the difference between the enhanced and the basic here is the presence of those on-site services and case management. And then just quickly jumping into our first finding before turning it back over to Rachel. And this is coming from our quantitative component of the study. You know, the chief purpose of the intervention was to stop the spread of COVID-19 among our population experiencing homelessness, and we found that it worked. So we pulled data from our state's COVID database, Washington Disease Reporting System, and matched it to HMIS and looked at our 3 cohorts over time from beginning of March when the pandemic began in our region, and looked at through last summer, so end of August. And so you can see the group hotel stayers are in blue and the congregate shelter stayers are in red and yellow. And so after some initial outbreaks in March and April among those folks, they were moved into hotels. And from that point on, you only see isolated cases in the group hoteling group. So those kind of sporadic blue dots that occur after that initial shift over to hotels. And then when we had sort of our second wave peak locally in the summer, that peak was experienced almost exclusively by those living in congregate settings. Very few, only isolated cases occurred among the group hoteling cohort.
So thanks, Christina. Part of the reason we were excited to partake in this study was because very early on, we started to hear about what we've grouped as these second group of findings, that the intervention provided additional favorable health and well-being outcomes. And this is something that we started to hear about anecdotally very quickly after the moves to hotels. And so our study gave us a chance to dive into that a little bit more systematically. So we'll take you through just a few of these highlights around these additional health and well-being outcomes. So first, I want to highlight that this experience of moving from a shelter into a hotel setting offered increased feelings of stability associated with access to private rooms. So you'll see quotes. I don't have time to read them all, but I'll highlight a few. And then we also have the link to the report, the full report at the end, if you want to see more details. But just this idea that being in a hotel room has helped to reestablish my self-esteem and dignity. Suddenly being able to think a little bit more ahead and not just from day to day. We also heard a lot about improved health and well-being. My mental health has vastly improved. My physical health has improved. I am sleeping regularly. I am not sick right now. So just thinking about the impact of sleeping in a hotel compared to what we know is the challenging conditions in a congregate shelter and having an almost immediate impact on improved health and well-being. We also heard about reduced interpersonal conflict. The idea that shelters are really high anxiety spaces, really charged, and moving to a hotel really provided a sense of peace and getting along ability. So everyone gets along better. We're much more tolerant. outbursts are few and far between. We get along. There's a sense of unity that we didn't have before. So in many cases, these are the same folks who had been experiencing shelter, right? Never a great time, but moving from these dense congregate shelters, feeling that hotels had an impact. We also had some quantitative findings related to this. Christina?
Sure.
And I do want to do a quick ping on time, so we want to make sure we have time for Q&A.
Okay, I will try to move quickly through this one then. Essentially, we looked at 911 call data from the areas where the congregate shelters were, and then the areas where the hotel shelters were. So it's kind of the same group of people, but being in the same locations, but the shift happens kind of midway through. And we find that there are fewer 911 calls generated by the hotel sites when the shelter stayers are in them compared to the congregate locations.
Thanks. We also heard just briefly an increased focus on the future, including housing, employment, and education. Remembering we're still in a pandemic, so folks didn't have necessarily immediate opportunities, but thinking about looking forward. We did see higher exits to permanent housing and generally more engagement with housing services staff. We don't want to overblow this too much. It was a pretty short study time-wise, but just overall seeing that there was greater stability, and when folks left, they were more likely to leave the shelter into a permanent housing situation. Finally, we just wanted to highlight what we think are the most important features of this intervention: having designated personal space, security procedures to keep residents safe. Some of these were put in place at the request of the community, the neighborhood, who was otherwise potentially resistant to this intervention. And yet we heard from the residents that these were important. Consistent access to food, storage of personal belongings, and the autonomy of being able to come and go as you please. And we wanted to highlight these because these are things that can be incorporated sometimes even without a hotel type setting. So finally, we've had the opportunity to continue these conversations over the past year as COVID has continued, and think about how we should move forward as a community, echoing many of the sentiments previously identified, that congregate shelters are not good. And we have alternatives. How can we move towards those alternatives that are helpful for all sorts of reasons? We have a full report available. We hope you'll check it out. It's also linked on the conference website. And just want to acknowledge and thank our funders and the rest of our research team, as well as the folks who shared their stories with us. Thanks so much.
All right, so we are going to go ahead and go into the Q&A. The first question we have for Sandra: can you talk a bit about how community engagement or engagement of communities or community-based organizations who work in service of people experiencing homelessness happened or could happen in the creation of a tool like the Cal Enviro Scan?
Yeah, certainly. So the utilization of Cal Enviro screen-based analysis for Project Room Key, since it was very much like a rapid response to the pandemic, and the kind of initial utilization of it and piloting of it, we did bring it to our public meetings for response and feedback, and then in this current round of using it for during the implementation of our emergency housing vouchers, we've been able to have a little bit more time to shop it around to folks, get some feedback from our CES Policy Council. Recently had a presentation with our Lived Experience Advisory Board, and they've expressed their interest and excitement to see moving forward how we can better integrate these equity-based tools into our work. But there's certainly a lot more we can do to expand and improve our efforts of ensuring that the community voices is fully integrated into the process.
Thank you very much, Sandra. Appreciate it. The next question we have was specifically related to the second presentation. It was about how are people getting their meals when they're in hotel rooms?
Sure. So during this time, meals were provided at all hotel sites as well as in the enhanced settings. So really during COVID, there was a shift similar to what we heard about earlier in not wanting folks to be leaving and coming back. And so in the hotel settings, there were still, each hotel had a provider that had been running the shelter was still in charge. So they coordinated with the provider to provide 3 meals a day.
Great, thank you very much. The next question I'll ask maybe both sets of presenters to answer. The question has 2 parts. So the first part is, what challenges did you face in keeping racial equity or pushing racial equity as the pandemic unfolded? And then were there new challenges that you had not experienced pre-pandemic that you are experiencing now? And maybe Sandra, you could start, and then we can follow up with Rachel and Christina.
Sure, yeah, so I would say one main challenge in ensuring racial equity within our COVID-19 response was timely access to data. In terms of PRK enrollments, it took a lot of, separate laws. So we're stretched in different places. And so it took some time for our data management team to be able to build the right, data dashboards so we'd be able to have more real-time access and understanding of who was being enrolled in PRK. And I think as I noted, PRK was launched towards the end of May, but we really didn't have the kind of like robust insight on kind of racial, ethnic backgrounds and gender and age and geography of all those individuals until about a month later. And so it was with that additional data dashboard information that we were able to begin to build out our strategy.
Thank you.
Just on the small perspective on the study, we were really cognizant of how do we get stories out quickly without making sure that we basically just have white men telling the stories. And then now we're talking about, what it's like to be in hotels. So we had kind of a pretty elaborate methodology of purposely sampling folks to participate in our research, which did rely on the providers to identify and help participate folks, but we provided them with specific lists of folks. King County did this based on making sure we were getting a sample that matched the diversity of the folks in hotels. So that was something very specific. We did attempt to speak with folks and in our report, you can see kind of the racial and gender diversity among the participants. We attempted to speak with folks in some of the congregate shelters and were unable to based on our time constraints, in part because there were continued COVID outbreaks and other challenges making it difficult for us to include that voice in the research. So speaking to the, what are ongoing challenges, it does feel like, there continues to be a missing piece. And but we do, I think, as a community, this is something we're continuing to think about. I'm sure Christina has something to add.
I think I agree with all that on kind of the microcosm of the study. We didn't have with our particular initiative or intervention, they were moving everybody who was in location A into hotel B, right? So there wasn't this sort of need to prioritize or select in. We are actively having those conversations now because in the wake of that experience in the study, our county passed a sales tax that is raising revenue that will bond against to build or to purchase hotels and create 1,600 new emergency shelter and permanent housing beds. And so for that, we're trying to kind of be forward thinking and be very intentional about that.
Great, thank you all very much. And there's one more question for all of you, and whoever wants to go first can. The question is, what do you see the role of local decision makers, elected officials, and others who engage in public policy making in support of the strategies that you have discussed?
Oh, I can start. I think that One of the things I think we made a lot of progress in during COVID because it really brought together a lot of different folks who've been thinking about things for a long time or experiencing things for a long time. I think especially the folks using our services are part of all these different systems that aren't necessarily talking to each other, whether the health system, housing system, homeless response services, education system. And I hope we can continue to think about these at a community level, which means not siloing based on, is this just a housing thing? Is this a homelessness thing? Is this just a health thing? But rather, these issues are so integrated. And so continuing to convene and elevate voices across the different issue areas and not treat them as isolated is something I believe we've made a lot of progress during the pandemic, and I hope we continue to see conversations at that level. Thanks.
I'll add here that for the LA context, the publication of the report on Black people experiencing homelessness back at the end of 2018 really helped provide a foundation for this conversation in LA. And at the end, or last year, at the county level, there was a creation of the Anti-Racism, Diversity, and Inclusion Unit at the county executive office, which has kind of become the home and responsible holder of the 67 recommendations that I noted earlier regarding how to reduce the overrepresentation of Black people experiencing homelessness. And so it's been great to see the work that really started in the community. Ad hoc committee was comprised of community members, researchers, service providers, so that see that the work of that community has really been carried forward and championed by some local policymakers and decision makers. And so there's kind of now a more permanent home and agency that can be help hold all of us accountable in making sure some of these recommendations and work is moved forward.
Good. I didn't know if anyone else had any last thoughts on that question or any other questions before we move into break. Take a moment. Any additional things presenters wanted to say? I really appreciate you all. Thank you. Oh, yeah.
Sorry, I'm wondering if I just threw my question in the chat, but wondering if that could be answered out loud if we have time.
Sure.
Yeah.
The question is, what are the agreements in place regarding research institutions? We lack these formal relationships in Oregon and therefore are behind on being able to pull this type of data.
So I'd say we didn't have any kind of formal agreement in place regarding this data. A lot of the data that we relied on in our study, we already had access to. But I think I have a tendency to sort of wax poetic about government research teams. So I'm going to take the opportunity to make a plug for that. I think we were able to move so quickly because we already had a relationship with Rachel and Greg, our other partner on the research from UW. And I think over the last 5 years, we've kind of consolidated and created a team in the county of almost 40 evaluators and researchers that work across a range of issues and build those relationships with our local university partners. And we've also created a lot of integrated data. So we've taken the time to create replicable monthly processes to receive data from Medicaid, from our jail system and HMIS, and connect all of those dots together. And so by having all that infrastructure in place at once, we're able to kind of get going more quickly when we see these opportunities arise. And by being internal, we see the opportunities and then can reach out to our external research partners to get the projects going. So.
And I'll just add that King County has invested heavily and I think been smart in the quantitative data piece and has a harder time funding qualitative research. So I think that, we all know the limitations of data, of quantitative data. And so being able to both have that external or the internal data piece already in place, but then bringing in the qualitative perspective, I think it's a nice complement.
I'll quickly add from the LA context, there's HPRI, the Homeless Policy Research Institute, So collaborative of researchers, practitioners focused on homelessness in LA. And recently, last year, finally got up and off the ground after several years of work, something called the Research Accelerator. So to kind of help streamline the process of researchers being able to request data from LAHSA, HMIS data, de-identified data, and in order to use for the research, and also to facilitate that process so that they can also more readily be able to provide feedback back to LAHSA on the ways that we can improve our system.
Awesome. Thank you all so much. I think we've got a couple of minutes. We're going to take a break at 11:20, but if there are any other questions that folks have or any other information that presenters want to share, we've got a couple of minutes to do that.
I'll just say that I'm happy to be in communication with any other who have more questions about what we've done in LA, and I can be reached at smcasa@lahsa.org, and I'll also drop my contact information in the chat. Thank you.
Awesome. Yes, please do that. I know in the small group that I was in, somebody was asking about kind of scope and geographic region for each of these projects. So it would be nice for folks to be able to reach out to presenters if possible. Thank you.
I want to add that I think for me, this research was such a bright spot during an otherwise really depressing time, and thinking about how we could come together as a community and really experiment in terms of policy in a way that there wasn't the political will before the pandemic. And so it really changed, I think, the way I think as a researcher around policy opportunities, and hear how these government nonprofit collaborate, like everybody had to move quickly, so they did, and then now we were able to shine a spotlight. The providers we talked to said, yes, of course congregate shelters are bad, we've known this for years, but nobody was listening to us. And now, you know, it's pretty common sense, and yet we were able to, I think we see this across our communities, highlight this in a way that hopefully will lead to more permanent changes even after the pandemic.
Thank you. And I did see one more question in the chat, specifically around your work, Sandra. Is LAHSA considering next steps to reduce racial disparities further?
Sure, yeah. So began to speak about our work looking at how we're allocating emergency housing vouchers. I'll also say that, you know, in this kind of pandemic moment, we've largely been in a responsive mode and frame of working, and we now have, in the midst of the pandemic, we created a new director of equity position. So in the process of kind of taking stock, lay of the land of what work we need to do both internally and externally. So at the moment, you know, we're looking at how to infuse equity within like particular policies and practices as they arise, but hoping to be able to take kind of a step back and think more broadly and systematically about what we can do to reduce racial disparities further.
Great. A huge thank you all again very much for your work, for your presentations today, for answering these great questions. That's great. Thank you, team. You really did an amazing job. This was a great event.
Yes, thank you so much.